Well, hello and welcome to this month's podcast. As ever, it's an absolute joy to bring you up to date with the very latest data in the wonderful world of rheumatoid arthritis. This is an episode that I'm going to use to review a paper by Fautrel and colleagues. It compares patient characteristics, tolerance of RA treatments, and long-term management with tocilizumab in people with rheumatoid arthritis over and under 75 years of age. And as ever, if you want to see the slides, summaries of this, and a whole ton of other stuff, head across to imidforum.com. That's imidforum, all one word, imidforum.com. And it's fabulous. Lots of stuff to see there. And, we always appreciate you coming and visiting. Alrighty, so the paper I want to talk about is the long-term management of elderly patients with rheumatoid arthritis treated with tocilizumab. It's a comparison of patients over and under 75 years of age. Now, tocilizumab was first marketed in France in 2010, and at that time indicated for adults with moderate to severe RA with inadequate response to at least one DMARD. Older adults are commonly excluded from randomized controlled trials based either on age limits and other eligibility criteria. Think of the kind of comorbidities that might preclude trial entry. And actually, if you remember back to the old Ted Pincus days, a large majority of the patients we treat in the real world are not eligible for clinical trials. So these kinds of subsequent analysis are really rather helpful to us. It was designed as a study to better understand RA management and particularly to look at the treatments provided for RA, drug tolerance and safety management, knowing that the elderly constitute a comorbid and frailer population. And this might be particularly important for a drug like tocilizumab, which, like many other medications in the field, are associated with increased risk of infections and potentially GI upset. Now, Fautrel and colleagues compared patient characteristics, tolerance of RA treatments, long-term management of tocilizumab in people with RA, and as I say, they looked at a comparison of over and under 75 years of age as a cutoff. So globally, patients with greater than or equal to 75 years presented with more medical history and comorbidities than younger patients. No surprise there. Within the 4 years prior to tocilizumab initiation, most patients were already treated with DMARDs for more than 1 year prior to the initiation of tocilizumab. And at initiation of drug therapy, the majority of patients received subcut tocilizumab, although this proportion was lower in patients aged more than or equal to 75 years. Tocilizumab maintenance was not statistically different in both patient groups, as well as the respective treatment maintenance rates at 1, 2, 3, and or 4 years after tocilizumab initiation. Now, most of the recommended blood tests were performed in more than or equal to 90% of patients, regardless of age group. Prophylaxis and treatment of osteoporosis was more frequently provided in the elderly, suggesting that frequent long-term use of corticosteroids in older RA patients was notably considered in addition to advanced age. That's, I think, quite reassuring. Patients more than or equal to 75 years experienced more severe opportunistic infections than younger patients, followed by acute cardiovascular events and hematologic complications. Causes of death were not available in the database, unfortunately, so no link could be made with the events of interest. Nothing terribly surprising there, but nevertheless, important data. It's a large French nationwide study conducted in patients who started tocilizumab and gives us really helpful information in a real-world setting. I think it's reassuring in the sense that for patients aged more than or equal to 75 years compared to younger patients, treatment maintenance and monitoring elements all seem relatively consistent. There were no new safety signals, for example, identified in older patients. As ever, one should personalize decisions, that is, individualizing them. We're good at doing that in rheumatology, and we should always bear in mind that that is an important part of our clinical practice. Well, that's the paper for this month. I hope it's been interesting to you. And as ever, if you want to view the full publications that we put up this month and to access our other podcasts and resources, head over to imidforum.com. And don't forget to subscribe to the Immune-Mediated Inflammatory Disease Forum podcast channel to make sure you do not miss any of our podcasts in future. You wouldn't want to do that now, would you? And as always, do make sure to let us know what you think. Leave a review. And most importantly, thank you so much for your attention. It's wonderful to have you joining us both on the forum and for these podcasts. Their whole purpose is to make sure that we do our very best as a discipline for the people who matter most. That's our patients. Thank you so much for your attention, and we'll see you next time. Bye.